Yeah, thank you. So, good evening, all the members of Maharashtra Ophthalmological Society and all the postgraduates who are joining from Maharashtra and across India. From Team MOS, we welcome you for this initiative about PG programs. This month is dedicated to glaucoma, so this is the second in series for such PG program today. And we are very happy to see great response from all the postgraduates for the previous webinar as well. Especially Dr. Sumit Lahane has taken a lot of efforts in coordinating all these PG programs, and he is going to do so across the year. Now, I would like to invite our president, Dr. Santosh Agarwal sir, to give his welcome address. Dr. Santosh Agarwal sir is a very well-known both entry segment and a retina specialist, an alumnus of Shankar Nethralaya in Chennai, and has been a leading practitioner in the city of Aurangabad. He has been a very dynamic president, has started many new
Both entry
initiatives
segment
in
and
this year already.
and has
And
been
this
a
is
leading
just
practitioner in the city of
probably a
Aurangabad.
month only into his presidency, and a lot of new ventures and a lot of new both scientific and non-scientific activities have already started. So over to you, Dr. Agarwal, sir, for your welcome address.
Thank you, Vardhaman. And also, I wish you a very happy birthday.
Thank you, sir.
Uh, respected teachers, PGs, fellows, esteemed colleagues, good evening, greetings, and warmest welcome to you all. We strive for the updation of our PGs, fellows in respect of their practical oriented skills. Instead of didactic lectures, we are going to have case presentations followed by panel discussion and expert comments by the teachers, which would definitely enlighten our young brigade and prepare for the practical exams. I appeal all the faculties to kindly stress on the basic examination techniques, understanding the basic concepts, and how to face the Viva questions in the exam. Thank you very much, Dr. Vardhaman, Sumit, Team MOS, all faculties and participants for curating this webinar and making it successful. I conclude my talk with the quote, knowledge is power, grab it as much possible. In the end, we retain from our studies only that which we practically apply. Thank you very much for the opportunity. Thank you.
Thank you very much, sir. And I think very well said. I'm sure postgraduates will be definitely, they will learn a lot and they will get inspired also from such initiatives. So over to Dr. Sumit now to please conduct the show. Over to you, Dr. Sumit. Thank you.
Thank you so much, sir. Thank you, Team MOS, for wholeheartedly supporting the post-graduation program of all of the state and, of course, guiding the nation for the same. I would like to thank all our panelists for being here. I will just shortly introduce them, though they don't need any introduction, but we need to thank them for taking out their time for being here. I would like to welcome Dr. Ajit Hazari, sir. Sir is a senior glaucoma specialist working in Aurangabad, and I must say that every patient from Marathwada to Vidarbha region who is suffering from glaucoma has been seen and touched by sir since last 17 to 18 years. Thank you, sir, for being there. Dr. Shirisha Senthil, ma'am. Ma'am has done her DNB from Arvinda Institute, of course, with the gold medal. She did her glaucoma fellowship from LV Prasad, and presently she is working in LV Prasad Car campus. And she is a very dynamic glaucoma specialist and very active in the GSI. Thank you, ma'am, for being here. We have Dr. Sohail Irfan, sir, who is a professor HOD of Nanded GMC. All of us know him not only as a professor HOD, but also for his great cataract videos and his new innovations in the cataract surgery. Sir, thank you for being here. Dr. Suhas Saravde, sir, who is professor HOD of Solapur GMC. And sir is not only able administrator, but he is also known for his being artistic in his photography and his pictures, which look much better than photograph itself. Thank you, sir, for being here. We have our moderator, Dr. Sarika Shinde, ma'am. Ma'am is a glaucoma specialist working in Mumbai and attached to Rajawadi Hospital. She is very keen on PG education and she will be our moderator today. We have two presenters, Dr. Akanksha from Solapur GMC and Dr. Anju Fogart from Nanded GMC. So I would request Dr. Akanksha to share her screen and start her presentation. Doc-
Thank you. Thank you, sir.
Please make it full screen.
Yes, sir. Good afternoon, everybody.
Are you able to do the full screen thing?
Resident 3. I'm Department of Ophthalmology. My patient is 28-year-old male. Patient name Ravindra Kamre, worker by occupation, came to the OPD with complaining of blurring of vision in right eye since 15 days. History.
Akanksha, your
Yes, sir.
slide is not moving. If you want, I can play it for you. Or you make it screen, please.
Okay, sir.
You can press that triangle button. Yeah, press that triangle button, please. Yeah, press it. Yeah, correct. You are on that slide thing only. Yeah, press that thing. If you don't mind, I will share the screen for you. Okay.
Okay, sir. May I, sir?
Yes, please.
My patient is a 28-year-old male. Patient named Ravindra Kamre, worker by occupation, came to the OPD with complaining of blurring of vision in right eye since 15 days. He on taking brief history, patient said patient was apparently all right 15 days back. After which patient started complaining of blurring of vision in right eye, which was insidious in onset and gradually progressive in nature. He also gave a past history of trauma to the right eye by tennis ball 2 year back. Patient did not approach for any medical advice back then. He has a history of recurrent episodes of pain and blurring of vision since last 2 year. No history of any previous ocular surgery. Family history, no similar complaint are seen in any family member. On general examination, patient is vitally stable, conscious, cooperative, and oriented with time, place, and person. Systemic examinations are within normal limit. On ocular examination, I am describing right eye first. His extraocular movement are full and free in all gazes. Eyeball is normal, eyelids are normal, pupil is irregular size, sphincter tear at 10 o'clock is noted, briskly reacting to light and well sustained. Vision on BCVA is 6 by 12, no improvement on pinhole. Lacrimal sac examination, on pressure there is no regurgitation. IOP of the right eye is 30 mmHg. On left eye ocular examination, extraocular movement are full and free in all gazes. Eyeball is normal, eyelids are also normal. Pupil normal size, briskly reacting to light and well sustained. Which was vision is 6 by 6. Lacrimal sac examination on pressure, no regurgitation is there. IOP is 12 mmHg. On slit lamp examination, explaining right eye first. Conjunctiva is normal, cornea is clear, but there is few iris pigment present over the endothelial layer. Anterior chamber is normal. Iris sphincter tear is noted at 3 o'clock and 7 o'clock. That and color pattern is altered. Lens is clear. And on left eye examination, conjunctiva is normal, cornea is clear, anterior chamber is normal, iris color pattern are normal, lens is clear. On fundus examination of right eye, medias are clear. Disc is circular in shape, normal in size, pink in color. 0.6 cup disc ratio is noted on slit lamp biomicroscopy using 78D lens. Margins are clear and NRR is healthy. Foveal reflex is bright. Visualized periphery is within normal limit. On left eye examination, medias are clear. Disc is circular, normal in shape and size, pink in color. 0.4 cup disc ratio is noted. Foveal reflex is bright and visualized periphery is within normal limit. On gonioscopic examination of right eye, using 4-mirror gonioscopic lens, right eye shows widening in right eye, showing the widening of the ciliary body band. Angle recession is also noted from 1 o'clock to 9 o'clock. Irregular dark pigmentation of angle noted in the right eye. Hence, my provisional diagnosis is right eye is having angle recession glaucoma, left eye is within normal limit. Thank you.
That was a nice presentation. I hand over to Dr. Sarika ma'am for the discussion.
Yeah, hello everyone. That was a nice presentation by Dr. Akanksha. Dr. Akanksha, can you just grade the hyphema? How do you grade the hyphema?
Ma'am, anterior chamber hyphema is in, we can grade hyphema in 5 stages. There is in grade 1, there is a micro hyphema is there. There is just blood stained aqueous is there. In grade 1, less than 1/3 of the anterior chamber is filled. In grade 2, 1/3 or half anterior chamber is filled. And is grade 3, more than 1/3 anterior chamber is filled. And in grade 4, there is a total anterior full chambered hyphema. And in grade 5, called as 8-ball hyphema, that is a complete blood coagulated blood is there in anterior chamber.
Okay. As your case, as you have diagnosed your case as a right eye angle recession glaucoma, I just want to highlight that the angle recession is the only visible marker of an invisible damage which is sustained by the trabecular meshwork after trauma. And around 9 to 10% of the angle recession will develop later on glaucoma. And if the angle recession is more than 180 degree, it is one of the important risk factor in the patients who develop the late onset glaucoma. So, and also you have to see the other risk factor, that is the patients with this kind of patients, whether they are having any predisposition to glaucoma. Because the 50% of them, they develop the glaucoma in the fellow eye later on. So my question to Dr. Shirisha madam here is that when do you, what are the criteria for the surgical intervention in case of any traumatic hyphema after any blunt trauma? In all trauma, closed trauma injury, hello? Hello?
Yeah, ma'am.
Shirisha madam, I think, yeah.
Internet. Ajit sir is also there. Ajit
Yeah,
sir.
Dr. Ajit, would you like to comment on the hyphema?
Can you hear me?
Yeah, hello. Yeah, madam is back online. Yeah. Madam,
Okay.
what are the criteria for the surgical intervention after traumatic, in case of hyphema, after traumatic glaucoma or after trauma?
Okay. So in patients with, let's say, an acute injury with fresh hyphema, if the let's say the injury has happened just a day or two before, and when the pressures of 40 or 50, and there is some amount of hyphema and there's a lot of inflammation, so that's not the stage where we will go and intervene. Or even if you see that there is hyphema in the anterior chamber, you don't want to go and do a wash, because most often it gets absorbed by itself. Yeah. In the presence of elevated intraocular pressure, let's say more than 30 or 50, so in patients with sickle cell, in fact, typically that's what we read. In patients with sickle cell, when there is elevated intraocular pressure and there is hyphema, you want to go and clear it up. Or if you have, let's say, a half chamber or more hyphema, pressures are not coming down in 2 or 3 days.
Okay.
and you know that the blood is clotted, then you may want to go and do a wash. So if there is a persistent elevation in intraocular pressure, despite all your best efforts in the first 2 or 3 days, then we may want to go and wash. So the younger they are, they're more prone to injury to the optic nerve they are. So if it is a child, and you see that in 2 or 3 days, if the intraocular pressures are not coming down, then you may want to take it up for a clearance. So I mean, that's what we would do. And sometimes the anterior chamber may appear as if it is almost clear, but you have a persistent elevation in intraocular pressure. When we do a gonioscopy, so that's not angle recession, because angle recession glaucoma typically is a chronic elevation in intraocular pressure that happens at a later time point. So immediately after trauma, even if you have angle recession, you don't call that as angle recession glaucoma, because post-traumatic, especially related to blunt injury, there could be multiple mechanisms. So starting from inflammation to the hyphema, the blood products as well as macrophages going and clogging the trabecular meshwork, and the steroids that are given in the postoperative period causing elevation in intraocular pressure. So I'm just giving a few examples of multiple mechanisms that can cause. At the same time, you can have more than one mechanism in the same patient. All right. So so that where I started with, in some patients you don't see too much of hyphema, but let's say 1 week, 2 week post acute trauma, you see that the intraocular pressures are just not coming down. And you don't have any subluxation of lens, no vitreous in the anterior chamber. And there possibly was some hyphema earlier, and now there is no hyphema. In a few instances, we have seen that when you do a gonioscopy, you will see a thick fibrinous membrane in the angle. So that hyphema, which is kind of resolved, has left behind a membrane, just like your glue, fibrin glue. You have a thick membrane which is sitting in the angle that is kind of covering up the trabecular outflow channels, and that can cause elevation in intraocular pressure. That also requires surgical clearing. You may have to go in and clear that membrane. So once you hold it and try and peel it, it comes off as if it's a ring that is present all around. So these to me are my practical experiences where I would go and do a AC wash in the early post-operative period. Sorry, early post-traumatic period.
May I ask one question?
Yeah.
Dr. Akanksha,
Yes, sir.
what is a ghost cell glaucoma?
Sir, ghost cell glaucoma is mostly seen in the patient with who is having a vitreous hemorrhage. It is basically ghost cells are basically RBCs which are degenerated and which are degenerated, and their hemoglobin is clumped to their cell membrane called a cell membrane, which is causing the hens body. They ultimately came and blocked the trabecular meshwork and form the called as that situation is called as the ghost cell glaucoma.
Okay, they are also called as Hakich cells because they have altered color.
Yes, sir.
But by the way, I wanted to ask you one more thing. As to what is the mechanism of angle resistant glaucoma? Seemingly, the angle has become more widened. So, the more widened angle is that we tend to have an illusion that this is a angle which has got a good facility of aqueous outflow. So, how will you justify angle resistant glaucoma where the angle depth has already increased? Because it is the comparative gonioscopy with the other eye that will tell you that this is angle recession glaucoma. Unless you compare
Yes,
that clock hours with the normal eye, you can
yes, sir.
conclude that it is angle recession glaucoma. Because you cannot, yeah. Can you tell me the mechanism?
Sir, in angle recession glaucoma, there is a tear between the longitudinal and horizontal muscles of the ciliary body. It may look like a widening of the angle, but the ciliary body, the apparatus which absorb the aqueous is hampered. That's why there is a rise in the IOP.
Okay, but that doesn't really, I mean to say, that doesn't look like a, because the answer to that is given in most of the textbook that there is already a collateral damage to the trabecular meshwork. And I
So
actually, madam,
there is also a desmentization of the trabecular meshwork
that
can
is
be there.
That is what Dr. Senthil madam has just now elaborated, that there is a formation of an desmet-like membrane by the
Yes.
endothelium that covers the angle, and there is a
Yes,
damage to the collateral damage to the trabecular meshwork at the time of trauma. So even though the angle is widened enough, but still you will have a escalated intraocular pressure. Okay,
Yes,
that
sir.
was good.
Yes,
That
sir.
was good.
Yes, sir. Thank you, sir.
Hello. My question to Shirisha madam is, what is the role of cycloplegics in cases of hyphema? And what is the AGM of a choice in in case of inflammatory glaucoma after
So,
trauma?
yeah, cycloplegics help to relieve the ciliary spasm. Any injury, any inflammation, basically because you don't want a ciliary spasm, and so to also to relieve the pain. So these are the two reasons why we may give cycloplegics. And medications of choice, obviously the aquasuppressants are the first choice. So let's say if the pressures are 30 or 40, you may want to add oral acetazolamide along with the topical beta blocker as well as topical carbonic anhydrase inhibitor. And if the pressures are not coming down, then of course we keep on stepping up. Then you add permonidin, the alpha agonist, and in desperate situations, if the pressures are really high, even in situations where there is some amount of inflammation, but then pressures are not coming down, we may also resort to adding a PG analog. So while that is not the first choice, but if we are desperate, if pressures are not coming down at all, and you know that we have to bring down the pressure, and you don't want to intervene surgically, and you should not intervene surgically at that point in time, so then PG analogs can be used. So first choice will be topical aquasuppressants and oral acetazolamide.
And what about, madam, in a young patient having the angle recession and even after the maximum medical treatment, the pressures are not under control? How early you should surgically intervene, and which surgery? I mean, would you like to go for the trab or like other like implant, or in young patient if it is
Yeah,
not
so
controlled?
yeah, like I said, when I say early post traumatic period, that means for me it is less than 1 month.
Okay.
So because typically you say it takes up to a month or sometimes even a couple of months for everything to settle down, all the inflammation and things like that. So I think I would look at the blunt trauma and elevation in intraocular pressure as presence of hyphema, presence of lens subluxation with vitreous in anterior chamber. So these are 2 or 3 situations where your pressures can be elevated. So if there are lenses subluxated and you see there is vitreous in anterior chamber, or if there is a rupture of the anterior capsule of the lens and things like that, we know there it needs a surgical intervention. You may want to conservatively try and reduce the intraocular pressure as much as possible, but that will require a definitive treatment that could be taken up for surgery as early as a week or 10 days also. In the presence of hyphema, which is not resolving, and the intraocular pressure not coming down, again, there we would want to go and do an anterior chamber wash of the hyphema, or like I described, a membrane sitting over the angle and the pressure is not coming down at all. In situations like that, we may want to do an AC wash. So AC wash, lens removal, lensectomy, vitrectomy, in the presence of subluxated lens are the only 2 procedures I would really look at. So I hear I'm hoping that there is no scleral tear, there's no corneal tear, nothing of that sort. But otherwise, it's just a blunt trauma with the injury to the structures that typically are affecting the 7
Rings
zones
of Campbell, yeah, right.
Yeah. Okay.
So, yeah, for the students here, to take home message from after any blunt trauma, that they have to look for this 7 anterior rings of tissue described by Campbell. The one is, I think, the sphincter tear. First is the sphincter tear, that those are the radial tears at the pupillary margin. Then the second is the iridoid light dialysis they should look for, which causes the D-shaped pupil, irregular D-shaped pupil. Then the tear at the anterior ciliary body, which we call as angle recession. And then one should look for the cyclodialysis cleft. Then the fifth is any tears in the trabecular meshwork, Then very important is the tear of the zonule or the zonular dehiscence, which can cause the subluxation or the dislocation of the lens. And the detailed retinal evaluation will sometimes will also reveal the presence of any retinal tears or the dialysis because of the detachment of the retina at the ora serrata. So these are the points which one should remember, that after any blunt injury or the trauma, this 7 rings of the trauma one has to look for after the slit lamp examination and after detailed gonioscopic and the fundus evaluation. Then after and I would like to it is very important for everybody, all the ophthalmologists, general practitioners and PG learning students, everybody, to master the gonioscopy to find out the cause of the glaucoma after trauma. And in trauma patient, the regular follow-up of the patients is very important, especially the patients with a raised IOP, because the angle recession later on and the glaucoma is very important in these patients. And of course, the detailed fundus evaluation. So anything, Dr. Shirisha Madam, you would like to add, and Dr. Ajit Sir, you would like to add in a traumatic glaucoma or the angle recession glaucoma for students?
Yeah, very, very well summarized. I think you have covered most of it. So, couple of points I will just add is the risk of the eye. Let's say early post trauma, they had elevation in intraocular pressure. We have treated and it has subsided. Now things are fine. So such patients, when do you call them for follow-up and how long do you follow up? I think it's very, very important to know that once you have had an injury, so they need to have a lifelong follow-up. How early you will, how frequently you will see is possibly, if everything is fine, maybe 1 yearly, but it's very important. And like what was also mentioned, that in fact we have published an article, I think during the time 2020 or 2021, during COVID time actually, where we in our own institute, in the series that we have treated, we have found that contralateral eye of the patients with blunt trauma in one eye have developed primary glaucoma, which means I would look at 10% of the patients develop primary glaucoma in the other eye. So is trauma in one eye a risk for the other eye developing glaucoma? No. So possibly it's like this. If there are, let's say, 100 people having similar amount of damage due to a blunt injury, all of them don't develop raised intraocular pressure. Some of them develop, some of them don't develop, right? In those who develop similar amount of similar severity of injury, but only few people who develop are possibly predisposed to developing glaucoma. Meaning my trabecular meshwork is predisposed, or rather it is functioning currently all right, but because of some risk of trauma or let's say steroid use or whatever was the reason, their trabecular meshwork is kind of more compromised and possibly they are predisposed to developing raised intraocular pressure. So possibly that's the only explanation I can give. So and that's the reason why we also have to follow them up and tell them that one eye trauma is not going to affect the contralateral eye, but possibly they are predisposed and hence they will also need a follow-up. So follow-up of the same eye with injury and the contralateral eye as well needs to be evaluated.
No. Dr. Sumit, are we supposed to go for the next case?
One question that we left out to ask, which I would like to ask Ajit sir. Sir, in this trauma cases, along with the angle recession, sometimes we do also notice peripheral anterior synechiae, which becomes again an intractable glaucoma case for anyone to handle. So, what is the best way to take care of such cases, sir? Peripheral anterior synechiae post trauma.
So, if there is angle recession, then PAS will give an added mechanism for the glaucoma, and you need to see, as Dr. Sirisha said, long-term follow-up is important. So just presence of PAS or scattered PAS will not really alter the treatment or the outcome unless it's really extensive. But for extensive PAS to happen, there has to be other extensive collateral damage happening to the eye. So just the PAS is unlikely to contribute to increased pressure. There would be associated collateral damage to the ciliary body, to the lens. There could be vitreous prolapse, and these causes could add to the gravity of the situation. The other thing which I wanted to add to what Sirisha said was that what I've noticed is that people whose one eye is weak or they see less by one eye, they tend to get injured more in that eye. So I've seen this happening in some of my patients where their vision was less in that eye, they got injured, they got angle recession also, and they developed glaucoma in the other eye also. Okay, so that is another thing you need to look at. Sometimes these patients present years later, 5 years, 10 years, 15 years later with glaucoma in one eye, and they never realized that their vision was less in that eye till recently. So again, to re-emphasize long-term follow-up and regular gonioscopy of these patients is important.
Good evening, sir.
May
Just
I
now,
ask?
I have one question to you, sir. Dr. Saravde.
Yes.
Now, just now you said that after trauma, sometimes the glaucoma occurs after many years.
Yes.
And sometimes it occurs in the other eye also. Hai na?
Yes.
Sir, what I mean to ask you is that whether we label this glaucoma which occurs in this patient as a primary glaucoma or only angle recession glaucoma, because they can have a predisposition for chronicible glaucomas. Na?
Yes, but these patients are not so common.
Right,
As the LVP study said, just
Correct.
about 10% or less than that. So vast majority of patients who have angle recession and who present with
vital,
glaucoma in one eye, advanced glaucoma in one eye, you should label them as angle recession glaucoma. And over the lifetime of the patient, he anyways has a risk of developing glaucoma, just as part of normal population also.
Right. They have trabecular damage. Right. Thank you, sir.
Yes.
May I ask one question? Yeah.
Yes.
Sumit, it's open for both panelists. Young patient with trauma, with maximum medical treatment, the pressure is not coming down. So, for a surgical intervention, a common ophthalmologist is acquainted with the trabeculectomy. Will this work in such cases, and what precautions a common ophthalmologist or comprehensive ophthalmologist should take while doing trabeculectomy in such scenario, or should it be referred directly for the tubes? What is the opinion of the panel?
What I feel is, I can answer first and then Sirisha can add her expert comments later.
Yeah.
So what I feel is the first primary aim is to control the inflammation. And very often we see that in young patients, once you control the inflammation, the glaucoma part also settles down significantly. And once the inflammation is down and still the pressure is persisting or it's fluctuating, you can step up the medication. If it's still not responding, you can also attempt SLT or MLT in these patients. That also works. Or something less invasive than a trap, because young patients, you don't want to do trap at first go, especially for new glaucomas. Okay, so you could do a mixed procedure like CAT or BANG, that kind of thing. And trabeculectomy as such would be a slightly higher risk, but I feel that still, if the inflammation is well controlled, a trap would still have a priority place rather than going in for a tube. If there are associated problems like vitreous prolapse or extensive damage, then one may consider a tube first. But if you have enough clear space to do a trap and you have a clear part of the angle where you can do a trap, then I think trap would still be my go-to surgery eventually for these patients. But after exhausting all the primary modalities.
Definitely, sir.
Sirisha, if you'd like to add, please.
Yeah. So a couple of things. Well said, Ajit. A couple of things for me. So let's consider the fact that Everything else has been done and the pressures are uncontrolled. There is also a disc damage that is developing, and hence we have to intervene surgically because of high IOP. So that's the situation where we want to deal with. So I would, angle-based procedures, in my experience, they don't do very well. I would say sometimes if you have, let's say, if it is a combined part of an angle recession, but primarily it is a primary glaucoma, maybe yes. But if they have had scarred, angle recession with scarred trabecular meshwork, then in our experience, the angle procedures don't do very well. So trabeculectomy definitely is my choice. If there is no subluxation of the lens and I don't have a problem doing an iridectomy, because for a trabeculectomy, we have to do an iridectomy. So for me, whether I will choose to do a trab or a tube is based on whether there is subluxation of lens or not, and is there a problem with the iris. So if these two are not a problem, then my choice would be to do a trabeculectomy. But always remember, even if the eye looks as if it doesn't have a subluxation of the lens, but these eyes, if you have a very deep anterior chamber, a lot of sphincter tears, you should expect that there would be some amount of zonular dehiscence. So as soon as you do an iridectomy, you may be surprised sometimes to see vitreous in that area. So that's the only precaution I would say that you need to take while doing a trabeculectomy in these eyes. If there is no zonular damage, then there is no issue. We can go ahead and do a trabeculectomy like any other eye, but prevent intraoperative as well as immediate postoperative hypotony. Maybe can use releasable sutures and make sure that the anterior chamber is well formed at the end of the surgery. If there is subluxation of lens and if there is likelihood that there is some amount of vitreous, let's say in a quadrant where you're not placing the tube, but in some other quadrant, then in situations like that, a tube would be my choice.
Thank you, ma'am.
Madam will go for the next case.
Yes,
Anju, Dr. Anju, you are ready?
Yes, sir.
Yeah, I will share the screen for you.
Sir, I'll share it. If it's okay.
Yeah, if you haven't, yeah, please go.
Yes, sir. Yes, sir. Share screen.
It's okay, Dr. Anju. It's ready with me. If that is comfortable with you, can I share? You can present like Akansha did.
So that will do. I'll try once. Just 1 minute.
Let me know when you're ready.
Yeah, okay. Good evening, everyone. Myself, Dr. Anju Fugat, JR3 in Department of Ophthalmology at GMC Nanded. I'll start with the case. Patient detail: a 60-year-old male, farmer by occupation, Hindu by religion, resident of Nanded, came to OPD with chief complaint of pain, redness, watering in the left eye since 20 days, and diminution of vision, both eyes, since 6 months. Patient was apparently all right 6 months back when he developed diminution of vision in both eyes, which was gradual in onset, slowly progressive, painless in nature. Now, in the last 20 days, patient started having pain, redness, and watering in the left eye. The past history: patient have history of diabetes mellitus and hypertension since 15 years and is non-compliant to the medication. Rest, no significant past history. Patient have no history of ocular trauma, ocular surgery, sticky discharge, exposure to chemical, vomiting, headache, fever with rash, joint pain, cough with weight loss, similar episodes in the past, or use of topical drug. In the treatment history, no significant treatment history. Family history, not significant. Personal history, within normal limit. In general examination, patient is well oriented to time, place, person. Rest is within normal limit except the RBS, which is 210 milligrams per deciliter. In the ocular examination, the head posture, facial symmetry, and eye alignment for both eyes is normal, and EOM is full and free in all direction of gaze for both eyes, with best corrective visual acuity for right eye 660 partial and for left eye finger count at 1 meters. In slit lamp examination, eyebrow, eyelid, eyelash, and conjunctiva is normal for right eye with clear cornea and normal content in the AC and Van Herrick grade 3 classification. In left eye, eyebrow, eyelid, eyelashes are normal with circumcorneal and conjunctival congestion with clear cornea and Van Herrick's grade 3 AC. In the iris, in the right eye, color pattern is normal. Pupil is single circular normal size reacting to light with nuclear sclerosis grade 1, IOP being 14 by applanation tonometer. In the left eye, there is vessel arborization seen at the pupillary margin from 10 o'clock to the 8 o'clock position. Pupil RAPD with the nuclear sclerosis grade 1, IOP being 36 by applanation tonometer. In the gonioscopic finding, in the right eye, there is Schaffer's grade 3 in all 4 quadrants. In the left eye, there is Schaffer's grade 3 in all 4 quadrants with new vessel seen at the angle in the temporal, nasal, and the inferior quadrant. On dilating the right eye, following with the findings of the fundus in the on indirect ophthalmoscopic examination, media was clear. The CDR was 0.3. Neovascularization was seen over 1/3 disc area with new vessels elsewhere. AV ratio was 1/3. Foveal reflex was dull, with dot blot hemorrhages seen over the macula, which are suggestive of proliferative diabetic retinopathy. On dilatation of the left eye on second day, similar findings were seen in the left eye as well. My provisional diagnosis with the above findings would be both eye proliferative diabetic retinopathy with left eye neovascular glaucoma. Thank you so much.
That was a good presentation by Dr. Anju. I would just like to tell a few points that in all diabetic patients, we have to do the gonioscopy, especially in the proliferative diabetic retinopathy cases, because it could be the first, sometimes it is first detected by the angle neovascularization. So it is very important to do the gonioscopy in even the diabetic patient who are having the retinopathy. So can you just tell Anju that who coined the term neovascular glaucoma?
Ma'am, the term neovascular glaucoma was coined by Weiss. Hello.
Hello, yeah. Hello.
Yeah, the term neovascular glaucoma was coined by Weiss, ma'am.
Okay. What are the most common causes of the neovascular glaucoma?
Ma'am, the most common causes of neovascular glaucoma are three majority of causes are diabetic retinopathy, then central retinal vein occlusion, and ocular ischemic syndrome. Diabetic retinopathy and central vein occlusion being the 33% each, and ocular ischemic syndrome 13%.
And how do you grade the neovascular glaucoma according to the neovascularization?
Yes, ma'am. The grading of the neovascular glaucoma is pre-rubiosis stage, in which there are tiny vessels over the surface of the iris, which are not visible clinically, but on fluorescent angiography, we can see the leaky vessels. And next is the rubiotic stage. In the rubiotic stage, the new vessels are seen over the surface of the iris at the angle as well. And next is the secondary open angle glaucoma stage, in which the fibrovascular membrane is formed over the iris and the trabecular meshwork, leading to the blockage of the aqueous outflow. And last is the secondary angle closure glaucoma, in which there is contraction of the fibrovascular membrane, which leads to the pulling of the iris over the trabecular meshwork, hence by blocking the aqueous outflow. Plus, on later stages, may develop peripheral anterior synechiae, leading to closure of the angle.
So,
okay. Madam,
Yes, sir.
I want to ask one question to Anju.
Yes.
You said that in diabetes and CRV occlusion, there is neovascularization of the iris and the angle, leading to secondary glaucoma. But why there is neovascularization of the iris and the angle in diabetes and CRV occlusion?
Sir, basically there is a retinal ischemia is there. Because of the retinal ischemia, there is release of the vascular endothelial growth factor, and the vascular endothelial growth factor, along with the flow of the vitreous to aqueous, the flow goes towards the iris, then to the angle. So there is VEGF at the VEGF flow over the iris and at the angle, leading to the formation of the new vessels.
After how many days that will occur in CRV occlusion?
In 90 days, around 90 days, that occurs.
Very good. And we can continue.
Yeah, as you rightly said, as you mentioned in your case, Anju, that your patient was a diabetic and hypertensive since last 15 years, but he was not compliant with his medication. So I would just like to tell you that in neovascular glaucoma, the cause or the whatever is the predisposing factor has to be treated. Like if it is a diabetic retinopathy or CRVO or any other collagen vascular disease, you have to investigate and treat the cause. And then only you can, tackle with these kind of cases. And especially if you have sometimes the rubiosis iridis, then you treat the patient with the anti-VEGF, and if required, after 1 week or later, you go for a trabeculectomy surgery or any implant surgery.
Yes.
So I would just like to ask Dr. Shirisha, madam, what is the choice of surgical procedure in an uncontrolled neovascular glaucoma?
Yeah, thanks for the question, and very well presented. So for me, the choice depends upon what is the underlying cause, whether it is diabetic retinopathy, central retinal vein occlusion, or ocular ischemic syndrome, or let's say vasculitis and things like that. So whatever is the underlying cause, that's important. If the eye is quiet, meaning like the patient has been treated adequately with the laser and plus minus the anti-VEGF based on the requirement, and eye is relatively quiet, then trabeculectomy is my first choice. If the eye is not quiet, when I say eye is not quiet, sometimes, let's say in ocular ischemic syndrome or in certain situations, the whatever you do, the new vessels are not going to completely regress, and there is some amount of inflammation which is ongoing, and the new vessels are persisting. In situations like that, then I may want to choose to do a tube surgery rather than do a trap, because one more episode of increased vascularization can lead to failure of the trabecular meshwork, failure of the trabeculectomy. So first choice is trap. Like I said, depending upon how the eye is.
And ma'am, what is the then role of the, transscleral cyclophotocoagulation? We have to wait in the patients who have a really painful red and the painful eye and with a very high IOP, like more than 40 or 60 in those cases. there is a real role of transscleral cyclophotocoagulation, or how do you, I mean, go about it?
Yeah, so I think transscleral cyclophotocoagulation and the cyclocryotherapy, we should not underestimate its utility. So in situations where, let's say, the media clarity is not good, somebody presents with vitreous hemorrhage, PDR with vitreous hemorrhage, and you're not able to do a laser, you may have given an injection, but that's not going to really take care of the problem permanently. In a situation like that, and the pressures are uncontrolled and angles are closed. So in a situation like that, what I would do is I would do an anterior retinal cryopexy along with the transscleral cyclophotocoagulation, but again a limited transscleral cyclophotocoagulation, which means I would do 20 or maybe 18 to 20 shots of TACPC along with cyclocryo, which means I have treated the peripheral retina, ischemic retina as well. And the vitreous hemorrhage may take 3 to 4 weeks for it to subside. So by the time the vitreous hemorrhage subsides and you're having a visibility of the posterior segment, then they can do a definitive laser. And if the pressure, sometimes the pressures just with this alone can control, sometimes it may not. That's okay. If it does not, then once the definitive treatment is done, we can go in for a trab or a tube at a later time point. In fact, I've done multiple things in reverse, like TSCPC, ARC, followed by the, whatever I explained now, followed by the retinal laser, followed by trabeculectomy when necessary. And let's say after a few years, if the trab fails, then you may have to go in for a tube. So we can salvage the eye. So TSCPC is not only for eyes with no visual potential, but in certain eyes with visual potential where the posterior segment treatment is not possible, TSCPC with ERC can be done.
May I ask one question to Dr. Ajit Hazari? Dr. Ajit? Hello?
Yes, go ahead, please.
Yes, you are actually, you do a lot of trabs. So my question is, like, because the trab is doomed to fail in most of the case when you contemplate a trabeculectomy. So what is your method of doing trabeculectomy? Is there any, besides the augmentation, you are using an off-label bevacizumab intracamerally also?
So if you are considering TRAB in neovascular glaucoma,
yeah,
the success rate is good if the underlying cause is controlled. So if the retinal ischemia is controlled with the anti-VEGF injections and the pan-retinal photocoagulation, then and the neovascularization as such is quiet now, it's controlled, then a TRAB is likely to succeed well. But if there is ongoing ischemia, it's a progressive condition, especially in PDR cases with very, very severe widespread ischemia, where whatever you do, the ischemia is going to progress, then a TRAB is likely to fail because the underlying cause is still there. So in my hands, what I've seen is that in retinal vein occlusions, the TRAB works well if you're able to control the underlying ischemia. And the uncontrolled diabetics with proliferative diabetic retinopathy, those are the really, really challenging cases to handle. And at the time of surgery, I do not use any anti-VEGF injections.
Okay.
I give anti-VEGF injections at least 4 days to 1 week before surgery. That's the minimum. For it to act, it should require at least a week or 10 days for the medicine to really act and reduce the new blood vessels. So if you can dilate the patient, then PRP works, but PRP also takes a long time for its real effect to come. So the best mode of action, if you have to operate a little early, is to use anti-VEGF injections. And any of the anti-VEGF injections will work in this situation. And the patient has to be counseled that he may require repeated injections even after the surgery to control the underlying condition. So if the underlying condition is well controlled, then TRAB is a good option.
Okay, thank you.
Sir, my next question is to both the panelists, Dr. Shirisha and Dr. Ajit sir. What is the AGM of choice to manage the immediate post-vitrectomy patients with a silicone oil insertion, and when, especially when they have the IOP spikes after the surgery, retinal surgery? So, how do you manage these cases?
I think a post-vitrectomy with silicone oil in the eye, you're looking at aqueous suppressants first,
Right.
and if the inflammation is not significant, you can definitely, I definitely use prostaglandin analogs also.
Madam, your take on this?
Yeah, so if it is immediate post silicone oil injection, I think what is very important to know, say drug of choice, I agree with Ajit that it is aquasuppressants, and then you will add brimonidine group, the alpha agonist, and then you will go on to use the other ones. But I think one of the challenges that we face is to understand why the pressures have gone up. So in post-silicone oil filled eyes, in the immediate post-operative period, it could be an overfill, which means that the pressures are not going to come down and they may require a partial removal of the oil, or you can have a pupillary block with the oil. Or there are situations when, in fact, in the recent times, we've seen a few patients where the whole of anterior chamber is filled with oil and the anterior chamber is deep. So you will not think that it is a pupillary block. It's not exactly a pupillary block, but the whole anterior chamber is filled with oil. You'll see a shine or a sheen-like thing, a reflection on the surface of the iris that tells you that there is an oil and tissue interface, and there is a reflection from there. So that tells you that the whole of anterior chamber is filled with oil. So once you know the reason why your pressures are elevated, then I think it becomes easy to treat. Unless you are dealing with, post oil removal, and this is just emulsified oil and tiny little bubbles are going and blocking the trabecular meshwork, that is a different ballgame altogether. But immediate post-operative period, I think understanding the mechanism will help us to treat. Because if you have a pupillary block, then obviously PI is going to help. AC is filled with oil, then you have to go and remove it. If it is overfill, then it needs to be removed. So only then we'll be able to take care of the glaucoma.
And what about the cases, madam, in patients with a neovascular glaucoma whom we have put the implant or the AGV or any other implant? How do you monitor the pressure? And how do you start with any other drugs? If the IOP still is on a higher side, how do you manage after the surgery these cases? Kind of refractory glaucoma.
You mean neovascular glaucomas?
Refractory to, after surgery also the pressure spikes. Yeah, after surgery also, if the patient is getting the IOP spikes, how early you start again with the medical treatment and what drugs you start?
Yeah, so if it is an AGV and we are talking about neovascular glaucoma, so irrespective of whichever type of glaucoma that we are dealing with, in eyes with AGV, which is the most commonly done drainage implant, we do start them on topical anti-glaucoma medications. I typically start as early as day 1 or day 3 or day 5, depending upon the intraocular pressure. If the IOP is greater than 6 or 7 millimeters on day 1, then I start them on topical aquasuppressants right from day 1 itself. So that can prevent the hypertensive phase in these patients and prevents very high intraocular pressure in the post-operative period. If the pressures are on the lower side, then I have to wait for 3 days or 5 days or 1 week and then start them on topical aquasuppressant. So we don't hesitate to start them on topical aquasuppressant. So you'll start medical treatment as early as possible. That prevents the a high IOP formation in the later post-operative period, a hypertensive phase, despite which you can have a hypertensive phase, but at least the height of hypertensive phase or the elevation in IOP will not be as high as what you would see if we don't give an early aquasuppression. Otherwise, the medications are the same. So we go by the same series.
So, in neovascular glaucoma, so treating the cause and the predisposing factor along with the management of the glaucoma is very important for for their comprehensive management point of.
So one point I would like to say, let's say we've done a trabeculectomy, it's working well. Like any other trab, let's say in the 1 year later, 2 years later, 3 years later, it's likely to, the pressures may start going up and it may. So in situations like that, when they come with elevated IOP, it's very, very important to do a gonioscopy. To do a gonioscopy in every one of these patients that we've done a trab, if the pressures are elevated, to know the cause. So in patients, typically, like what Ajit was saying, in patients with, let's say, PDR or sometimes even OIS for that matter, if their systemic condition is not controlled very well, then you may have recurrence of new vessels. And when they have recurrence of new vessels, sometimes you can have the rest of the angle may be open, but you have new vessels, and what was well controlled now, suddenly the pressure shoots to 30 or 40. So rather than just adding topical anti-glaucoma medications or intervening again, we need to understand the cause. And if there are new vessels coming back again, then we need to treat the posterior segment problem. And then you move on with your glaucoma management.
Any other things you would like to tell, Madam, to PGs to remember in view of neovascular glaucoma and also
Just one point I would like to share and tell everybody is that so there was a study that we did where we compared how we manage neovascular glaucoma versus how things are being done in the West. So if I have to specifically say, this was in comparing UK with the Indian. So this was actually a multi-centric study comparing several centers in India and one center in the UK. One center meaning like NHS in the UK. A striking difference that we found is not doing PRP for patients with neovascular glaucoma, but just giving repeated Avastin and going ahead and doing interventions like trabeculectomy, tube, and things like that. We should remember that anti-VEGF injections are only temporary and they will only help to bring down the VEGF levels at that moment, but it's not going to actually take care of the cause. So while we may give anti-VEGF injections in the early time for temporary suppression, but definitive treatment has to be done. So that's very, very important. I think that was a striking difference that we saw, and it was very difficult for us to, and I think this was not just in one place, in multiple places, this is what has come out. So while it may be difficult to do a laser because of multiple reasons, I think we should make every attempt to do adequate laser to the posterior segment and identify, let's say if it is ocular ischemic syndrome or situation like that, you may have a combination of problems. For example, a diabetic patient, one eye can have a PDR and the contralateral eye can have a mild NPDR. Very unusual for a systemic condition to have severe disease in one eye and almost normal or a very early disease in the other eye. In a situation like that, I would actually look at this as a combined diabetic retinopathy with ocular ischemic syndrome. The eye that has more of ischemia is presenting with a PDR, whereas the contralateral eye is presenting with a very mild disease. So you can have a combination of two pathologies in the same eye also. So I think that's the only message I wanted to give. And NVG is an ocular emergency. And it is up to us to pick up the condition, treat it, and save the eye. Or if we are a little, complacent, and especially if it requires a coordination between two different specialties, retina and glaucoma, and if the patient, falls between the cracks, we may even lose the eye.
Thank you, Madam. I think now we'll just go for the next two case discussions, interesting cases. Dr. Sumit, can you just share those slides?
I will.
So I'll just go to the first case. Here, the 36 years old male with a both eye visual acuity 6/6. He was diagnosed as a glaucoma. He came with a complaint of intermittent pain only in one left eye. And the intraocular pressure in the right eye was 25 and the left eye was 32 millimeters of mercury. He was started with the timolol in the left eye along with the prostaglandins and ripasodil. This was his disc photograph. The right eye was normal, around 0.5 CD ratio with a healthy NRR, and the left eye was around 0.8 to 0.9 CDR with a bipolar thinning of the neuroretinal rims. Then this is his left eye picture. He was having the left eye, the nevus of ota with the pigmentation you see all over the diffuse pigmentation. So it was a case of nevus of ota in the only one eye. And this is his slit lamp picture, which was showing the pigment deposition on the endothelium. And on gonioscopy, the angles were densely pigmented. It was a grade 4 homogeneous pigmentation in the angles. And like few angles, it was the iris processes also was visible. And my question here to the panelist is, what will you do in this young unilateral glaucoma? Secondary glaucomas, would you go for the trap first or the tube first? And what will you treat? What is your mode of treatment in the other eye, which is not having glaucoma at present? I mean, with the raised IOP, but the no obvious optic disc changes. Dr. Shirisha and Dr. Ajit Hazari, would you just like to comment anything on this?
Yeah. For my first choice would be to go ahead with a trab for the left eye. If the glaucoma was not so advanced, I could have considered a GAT for him. But otherwise, for a trab, because the iris as such looks okay. There doesn't seem to be any obvious abnormality in the iris.
Madam, what would be your take on this?
Yeah, so first I would like to actually understand why the right eye pressure is elevated. So nevus of ota sometimes can be oculodermal melanocytosis, can be unilateral, can be bilateral also sometimes. So you may see very minimal pigmentation, but one side you can have gross pigmentation. So is the same disease present but asymmetrical? And are we dealing with a condition that is bilateral but more in one eye versus the other?
No, it was only in one eye, ma'am. It was ipsilateral only in one eye nevus of ota. The other eye, the angles and the anterior segment was absolutely normal. So the left eye pressure was high, but I think at one time the right eye pressure was also, right eye pressure was more, it was fluctuating. It was sometimes it was about 20, but it was in about 20 range only always.
Oh, okay. Does this patient also have any other pathology, choroidal hemangioma, any other facial hemangioma?
No.
Okay. So yeah, that's one thing that I would like to rule out, because usually oculodermal melanocytosis,
they have the choroidal hemangioma.
Yeah, can be associated with a condition called phakomatosis pigmentovascularis, where you can have a bilateral hemangioma and pigmentation. It's associated with Sturge-Weber's and Portvine birthmark. So you can have these conditions associated. So if all of that is ruled out and we see an eye like this, a trabeculectomy would still be a choice. I would not go for a tube procedure to begin with. Angle procedures we can do, but I'm worried because if this condition is associated with, so if there is some amount of episcleral hemangioma or situation like that where you may have raised episcleral venous pressure, then I'm worried about the back pressure in these eyes. So if not, if all that is ruled out, then maybe a GAT one can consider, but I would actually go in for a trab procedure in these eyes.
So this is, madam, a kind of a pigment dispersion kind of glaucoma, or a variant of that type which is presenting unilaterally. Is there any role in this kind of cases because of the release of the pigment, or the melanocytosis is the only cause which is causing glaucoma here? What do you feel? because
Yeah,
he's
so
having few signs of the pigment dispersion. Along with the primary cause here is the nevus of Ota, and the mechanism here is the melanocytosis, which is obstructing the aqueous outflow. So I mean,
yeah,
how
so
to
just
deal with
like just like how we have increased pigmentation on the sclera, you have increased pigmentation of the trabecular meshwork. So basically, it's melanocytosis, like you rightly said. There is excess pigmentation that is present. So whether we call it dispersion or not, it's that term I'm not quite sure, because there is no so pigment dispersion typically occurs when you have a something that is kind of rubbing on the posterior pigmented layer, right? So whether it is the posterior bowing of the iris, or the zonules being abnormal, or the lens being a little shaky, so any of the zonulopathies that could be associated with things like that. So if all of that is not there, then it will be difficult to call it as pigment dispersion. So here, yes, there is excess pigmentation, and that can get dispersed anyway with pupillary movement, and with gravity. Inferior angle may be more pigmented compared to the other angles.
So we have to treat it as a secondary open angle glaucoma.
Yeah, it will be secondary open angle glaucoma.
Okay.
Yeah.
So is it fair to ignore the fluctuation in the IOP in the right eye?
Right eye, right. Yeah.
No, it's not. We need to worry about whether you have, let's say, this person is likely to have a primary open angle glaucoma, which is having an associated secondary pathology in the left eye, and hence more severe disease in that eye. Maybe two problems in one eye and one problem in the other eye, like the way you see in pseudoexfoliation.
Right.
So that's
we have to
considering the age. Considering the age of the patient, can you consider it as juvenile open angle glaucoma, maybe a little late onset in the right eye?
Yes.
Yeah.
Shall we go for the second case?
Sure.
Here the 30 years female, the surgery, PRK was done 3 years back, who presented with the pain and the photophobia. And the intraocular pressure in the right eye was 28 and the left eye was 34. Her central corneal thickness in the right eye was 440 and the left eye was 428 after the refractive procedure. She had an episode of a conjunctivitis 3 weeks back when she presented to us, which was followed by the SPKs over the cornea, and which was treated by topical steroid for 10 days with a prednisolone acetate 6 times daily. This was a fundus disc for a picture. She was having a like myopic disc with the right eye CD ratio was around 0.6 to 7. With the left eye was a myopic and tilted disc with a more deeper cup than the right eye with the peripapillary atrophy. And what will you do in this kind of post-refractive patients who are having the high IOPs? And do we treat do we treat these patients as a steroid response glaucoma? And what, when do we stop steroid? How do we treat them? And we start the AGM, and what AGM we should start? And especially how to monitor the glaucoma in a post-refractive cases, surgeries, because they're having a altered corneal thickness, and they're having the very thin corneas. So both the panelists, I would like to have your take on this kind of glaucomas.
Okay. So the corneal thickness is about 440 post the laser vision correction. So that we can safely assume that there's been an ablation of about 60 to 70 microns, at least. Okay, so these are thin corneas, but iatrogenically thin, and a pressure of 25 and so on is really, really high for these patients. So my first assumption would be that it is a steroid response and the patient is a steroid responder. And accordingly, I would treat with aqueous suppressants first, and then add brimonidine, and also can consider a prostaglandin analog for sure. There's no contraindication to that. If the pressure is getting lower to somewhere around less than 15 is what I would aim at. Even that would be slightly on the higher side for this patient, actually. And how do I know what is the normal pressure for this patient? Well, whatever pressure I've taken at the first go is my baseline pressure. And considering the corneal thickness, I would prefer to have a pressure somewhere in the low teens. How do I monitor this patient? Well, disc picture, changes in disc picture will take a long time. OCT is fraught with problems in high myopes, and analysis of progression would be difficult. But whatever is the baseline OCT, whatever OCT I've got at the first go would be my baseline, and I would be more proactively doing OCT more often for this patient. What is more reliable is HVF or perimetry, but perimetric changes will take a long time to reflect. So either ways, all our diagnostic modalities are a bit compromised in this situation because of the high myopia and the hydrogenically thin corneas. So whatever the patient presents with first is my baseline assessment, and I would be more proactive in following this patient up more aggressively, more closely to see if there are any changes happening. If it is just a steroid response to 10 days of prednisolone acetate, I would expect it to settle down in a month's time with AGM. That's it.
Dr. Shirisha, madam.
So very well summarized, Ajit. I don't have anything more to add. So yeah, I would.
Ma'am, I have one question to you. In
Yeah.
like in a high myope patients, like this kind of patients who have done the surgery, I mean some LASIK or something, they are usually having a myopic disc, and it is difficult to monitor them with the OCT and the perimetry. So many of the general ophthalmologists, like they are confused how to, like monitor them on OCT and also on the perimetry, because the picture is not always that ideal. So
yeah. So
how
I
do
do a baseline disc photograph and baseline HVF. Visual field is something that anybody whose optic disc looks a little suspicious before advising a refractive surgery. I think it's important to do a visual fields. Just the way we do their biometry and keep it for them for the future, same way visual field also has to be done, and a copy has to be given to them, and we keep it as well. So baseline disc photograph, baseline visual fields, and how do you follow up of the two OCT? So anything that has a structural, some myopes, optic discs may look normal. Some of them have very tilted disc with extensive peripapillary atrophy and things like that. So anywhere where you have an anatomical abnormality, OCT is not a great test to follow up. Having said that, I agree with what Ajit said, that you do a baseline for the patient, and over a period of time, what happens to it with regards to the thinning of the RNFL is something that you will evaluate. So, but otherwise, I use visual fields for them. So for LASIK is a little different. So PRK is different. All of them have thin corneas post-refractive surgery, but with LASIK, we also need to worry about the pressures. The one condition that is typical with any flap-based refractive surgery is the interface fluid that accumulates, and you can have a condition called interface fluid syndrome, where we will be underestimating the intraocular pressure in several of these eyes because of the interface fluid. And situations like that, we need to understand that none of the available tonometers can actually record the intraocular pressures correctly. We have to do the IOP just outside of the flap using either a tonopen or an eye care tonometer, anything that has a smaller area of contact, basically. With GAT having 3 point, you require a larger area to contact, and GAT typically gives underestimation of the pressure. So one condition which all people who deal with refractive surgeries is this. So high IOP, you can have a paradoxical low intraocular pressure estimation.
Oh, and how do you measure them? I mean, corneal thickness after surgery by OCT or by ultrasound pachymetry? Which is the which is the most preferable? Or
Whatever is available is
Available.
fine. Yeah. I don't think there is any specific preferred one. All
Any
we
other-
know it's just a range, right? So if the
Right.
toxicity is in 400s or 500s, so that's all. 1-2 millimeters should not, microns should not make a difference.
So as you said, like you have to, monitor the IOP with some tonometer which is having a small caliber. So if there is a non-availability of the tono pen or something, then if somebody is checking the IOP with the applanation tonometer, they have to keep in the mind that the IOP is always underestimated because of the thinner cornea.
Yeah, IOP is underestimated with every tonometer.
Every tonometer.
With specifically what I mentioned was with regards to the interface fluid syndrome, where GAT is a good option. But other situations, GAT is fine. But we know that it underestimates.
Okay.
So we have to keep the pressures really under low levels. And these
low levels, and you have to monitor other signs also, like disc and the things you have to keep monitoring, fields and disc changes.
Correct.
To prevent the progression. Okay. Any other point, madam and sir, you would like to add to this kind of glaucomas?
So once the one point is like steroid response, and then whatever it may take a couple of weeks or a month for the pressures to go down, but we also have to make sure that these patients have a risk of glaucoma lifelong. So I think it's also important to educate them. And once they have been a steroid responder, I would be a little skeptical in not following them up. I would say maybe 6 months, 1 year, just at least for the first couple of years, follow them. And if they are fine, it's okay. Otherwise, they may at some point in time develop a juvenile open angle glaucoma, and we may miss an opportunity.
So you have to keep them, monitoring and following up for quite, you can say lifelong.
Yeah, lifelong,
quite
but
a long time.
Not to really scare them, but
yeah.
The worry is they are young, and people may underestimate the pressures, and we may miss the glaucoma until it is very advanced.
Yeah, I wanted to make a point here. Most of these laser vision correction patients, usually most of them, we would expect them to have good maculas. The discs may look abnormal, but the maculas are usually good. And here, I think the role of ganglion cell layer analysis in serial monitoring of these patients will also be very helpful in picking up early changes. So perimetry is there, of course, and rather than relying on RNFL, if there is a myopic disc, then the ganglion cell layer analysis over a long period of time will also be pretty sensitive.
May I ask one question? Thank you.
Sure.
In a steroid, this is regarding the steroid response glaucoma. In an early post-op cataract case, clean case, no complications, very nice. Say for day 1, 6.6. But in the third or fourth day, usually I found that the pressure is raised. Now the thing is, it is already on prednisolone. So we have to stop get an idea. Pre-op, the pressure was normal. Post-op, everything is clear, but the pressure is raised. So in this case, stopping a prednisolone and shifting to softer steroid will help. And how to tackle such cases, this glaucoma, in such cases.
So we routinely check patients' IOP in post-op period of at least at 1 week, and starting from 1 week. And if I find that the pressure is high, I immediately stop the prednisolone acetate and keep the patient only on nepafenac. But I explain to the patient that the post-op healing may be prolonged a bit. So I keep the patient only on nepafenac, no steroids, and I also will add a timolol brimonidine combination, or just a timolol, depending on the level of the IOP. At the same time, I would also do a baseline macular scan at 1 week when I see the high pressure. because I want to look out for any early post-op CME that may be happening in this patient.
Okay, sir.
Yeah, so I switched to a softer steroid if it is 1 week post-op that you are assessing. So we normally check intraocular pressures right from day one. So GAT is done for them even at day one post-op. But like you said, early post-op, 3 days, 4 days, fine. But 1 week, the pressures are elevated. Usually for a steroid response to happen, it takes at least 2 to 3 weeks. But sometimes you can see it at an early time as well. But if you see it, then if it is 1 week, then I switch to a softer steroid and then give them Diamox for 2-3 days. That settles down normally if it is not a pre-existing glaucoma. But if the pressures are very high, like if it is in the early 20s, it's okay. But if the pressures are going beyond 30 or so, then I'm going to switch to a softer steroid or stop it and put them only on NSAIDs, put them on oral acetazolamide and call them back in a week and see. So generally they respond. It's not like we should not give a topical medication, but it's just that you give it and then we stop it. So once you stop, you have to call them back for remonitoring. Yeah. Since many patients come from outside, so it becomes very difficult. So, but if you're giving a Diamox, then it's easy to stop. And once you discontinue, you know that the pressures are fine, then you don't have to worry much about it.
Thank you, ma'am.
That was a nice discussion. I would like to thank Dr. Shirisha Madam, Dr. Ajit Hazari Sir, and all the MOS members and the seniors who gave me the opportunity to moderate this session. I would especially thanks Dr. Sumit for giving me this opportunity. Over to you, Sumit.
Ma'am, vote of thanks. We have Dr. Aditi ma'am to do that.
Yeah. Okay.
So just for the official vote of thanks from Team MOS, I would first like to thank Dr. Akanksha and Dr. Anju for wonderful presentations. I'm very much sure that these presentations and discussion have surely helped you to boost your confidence, and expert comments and discussion has enriched your knowledge. Thank you, Dr. Sarvade sir and Dr. Sohail Irfan sir, for mentoring the students. Many thanks to our national faculty, Dr. Sirisha, and our own MOS faculty, Dr. Ajit Hazari sir, for sharing their pearls of wisdom and experience, which has surely enriched everyone's glaucoma knowledge. Thank you, Dr. Sarika Shinde, madam, for wonderfully moderating the session, and special thanks for saying yes on such a short notice. Thank you, our own President, Dr. Agrawal sir, our Dynamic Secretary, Dr. Atul Kadhane sir, Dr. Mandar Paranspe sir, Vardhaman, who is the birthday boy for today, still he's there around. And thank you, Sumit, for all the efforts for curating this PG activity. Importantly, I would like to thank Team Entod and the technical team for their support. And last but not the least, thank you all who have joined us live from different platforms. Thank you so much from Team MOS.
Thank you, ma'am.
Thank you,
We'll have
everyone.
one photograph. Atul, can you take the photograph? Everybody, please.
Sir, unfortunately, my camera is not working, so I'm not visible.
Okay, that's okay.
So
we will Photoshop you.
Surely, sir.
Okay, thank you. I taken the screenshot.
Okay, thank you so much.
Thank you, everyone.
Thank you, Shirisha ma'am, Ajit, Sohail, Sarode sir, and everybody. Thank you so much.
Such a nice academic activity.
Very nice discussion.
Yeah.
Thank you.
Thank you all PGs
Thank
also
you,
for
everyone.
wonderful presentations.
Yeah.
Very well presented and answered also.
Thank you all. Good night.
Thank you all. Good night, everyone. Thanks.
Thank you.
Thank you.
Good night.